pregnancy. So this is our outline. So teenage and also used interchangeably with adolescent as an age group between 10 to 19 years of age. It is a stage where major physical, psychological, and social changes take place. Teenagers make about 1.2 billion of the world's population, which is 14%. Teenage pregnancy is a global health crisis. They can have adverse maternal and neonatal outcomes. Teenage pregnancy has socioeconomic as well as psychological implications. They're more likely to occur in socially and economically disadvantaged communities and can lead to intergenerational cycles of poverty. So teenage pregnancy accounts for an estimate of 21 million pregnancy per year in the age groups 15 to 19 years of age, and 2 million in the age groups less than 15 years of age in low and middle income countries worldwide. More than 50% of these pregnancies are unplanned, and of these pregnancies, we get 12 million deliveries per year. Around 5.6 million end up in termination of pregnancies, and around 3.9 million of these terminations of pregnancies are illegal. So rates of teenage pregnancies have been uneven in different regions of the world. In the South African context, South Africa has the highest rate of teenage pregnancy globally, with the teenage pregnancy rate of 30% between the ages of 10 and 19. 65% of these are unplanned, and 33% of these teenage mothers do not return to school after pregnancy. And then the teenage pregnancy rate is the number of conceptions per 1,000 women under the age of 20 years. As per Stats South Africa has had a total of 90,037 teenage deliveries between March 2021 to April 2022. KZN had the highest number of deliveries with 26,296, followed by Limpopo with 15,365, and in third place was Eastern Cape. Limpopo had the highest number of terminations of pregnancies in the 3 years, 2017, 2018, as well as 2019. There are currently more than 100,000 teenage pregnancies per year. So the determining factors of teenage pregnancies are early age of sexual activity, low level of education, low socioeconomic status. Sexual assault increases the chances of unplanned pregnancies. Then child marriages also. There's an increased number of child marriages, which influences the pregnancy. Lack of support, access or no access to contraceptives, either due to resource scarcity or not that they're not easily accessible. Religious beliefs, culture, and family behavioral models, substance abuse, as well as social media influences. There was a systemic review and meta-analysis that was done that included 14 studies, and the results of the 9 studies of the 14 were also find the determining factors of pregnancies as listed above. Looking at social aspects of teenage pregnancy, a quarter of teenage pregnancies do not return to school after pregnancies. This is a result of difficulties in simultaneously balancing the demands of motherhood as well as education. So teenagers usually feel that they've disappointed the family and the communities, and they feel that they've brought shame and then embarrassment to the family and the community. So teenage pregnancy is usually associated with stigmas from the family members. They usually socially withdraw and are rejected by their communities, and they also fear the healthcare workers' hostile attitudes, and they have financial constraints, and they receive rejection from their fathers of the babies as well as their peers. They're prone to school dropouts, and there's also this repeat poverty cycle. They lack, there's also a lack of future opportunities because of those newly found responsibilities. So it's recommended that social workers ensure that their mothers are aware of the financial and educational supports that are available to them. So clinical aspects of teenage pregnancy, there's an increase in adverse obstetrics and neonatal outcomes when it comes to teenage pregnancies. Complications during pregnancy and delivery are the second leading cause of death in the age groups between 15 and 19 years of age. The United Nations Population Fund in 2007 reported teenage pregnancy, reported teenage groups of 15 and 19 had a double risk of maternal mortality when it was compared to the age groups 20 to 24-year-old. And also 70,000 of this age group die annually secondary to pregnancy and labor-related complications. Prenatally, teenagers might not be aware that they are pregnant, so clinicians need to have a low threshold of pregnancy testing. So in order to detect pregnancy early and encourage antenatal care attendance. So contraceptives should be encouraged at any opportunistic case. Canadians guidelines recommend testing of STIs at booking third trimester as well as postpartum. This recommendation comes based on the risk that the teenagers are at high risk of preterm labor, pre-labor rupture of membranes, and also endometritis. And there also needs to be an active approach to contact tracing. Canadian guidelines also recommend a dating scan that includes a cervical length screening because, as we mentioned, of the high risk of preterm labor with teenagers. So when it comes to antenatal care, it requires a multidisciplinary team. Teenagers have a lower antenatal care attendance with 90% less likely to have more than 5 visits. They're usually late bookers, either because they were not aware that they're pregnant or they are concealing their pregnancy or have the anxiety of being judged, or they have no knowledge or lack the understanding of the importance and the relevance of their antenatal care, or they fear the unfriendly and judgmental healthcare professionals, or they are unable, because of practical challenges, they're unable to make dates due to school or financial issues. They also defaulters to follow up, which increases risk of complications to both the mother and the baby. So these are the most common antenatal complications that occur in teenage pregnancies. Preterm labor, PET and eclampsia, STIs, anemia, cephalopelvic disproportion, endometritis, and maternal mortality. Antenatal care needs to be teenage friendly and create a secure, safe environment for the teenage mothers. There needs to be a unique sensitivity is needed during pregnancy, intrapartum, as well as postpartum care. So fathers need to be included in the pregnancy, prenatal, and infant care. Social studies have mentioned that the fathers mentioned that they feel excluded or even blamed for the pregnancies. So they also need to be a specialized teenage antenatal clinics, and they are high-risk pregnancies. So pregnancy outcomes improve if optimal antenatal care is achieved. So after confirming an intrauterine pregnancy, the mothers needs to be counseled and provided with all the available options or outcomes of pregnancy without judgment. Those include termination of pregnancy, continuing with pregnancy, or adoption. And there also needs to be counseling with regards to diet, substance use in pregnancy, as well as STIs and contraceptives. An anomaly scan needs to be done at 20 to 24 weeks to exclude congenital anomalies. Teenage pregnancies are associated with an increased risk for congenital anomalies, and the most common one found amongst teenagers are CNS anomalies, anencephaly, spina bifida, and hydrocephalus, sorry, gastrointestinal anomalies, gastroschisis and amphalocele, musculoskeletal anomalies, cleft lip or palate, etc. So when looking at nutrition, teenagers have poor nutritional diets, and the poor nutrition is either associated with impaired fetal growth and low birth weight. It's been postulated by studies that the impaired the teenage mother is also still growing, so the mom competes with the baby for nutrition, which may result to impaired fetal growth as well as low birth weight. But dietary interventions show to reduce the incidence of teenage mothers delivering low birth babies. Looking at substance use, teenagers have a higher rate of substance use. A large cohort study showed that smoking, drug and alcohol misuse are also more common in teenage mothers compared with pregnant mothers at the ages of 20 to 35 years of age. Martin et al. Found that teenagers engage in substance abuse while pregnant, and then this increases the risk of miscarriages, preterm labor, low birth weight, small for gestational age, stillborn, hypertensive disorders, fetal alcohol spectrum disorder, as well as sudden infant syndrome. So looking at STIs, young people at ages of 15 to 25 have the highest rates of STIs. So the incidence of STIs is increasing more, especially in teenagers. So screening is recommended. Syphilis is also on the rise again with increasing cases of congenital syphilis. So routine testing for syphilis is recommended. In South Africa, we routinely screen every 4 weeks in an antenatal period. So STIs may cause UGR, preterm labor, stillborn, postnatal maternal complications like endometritis, as well as neonatal infections. Ngagamba in 2021 found that approximately 1,300 adolescents have and young women are HIV infected in South Africa weekly. Teenagers in sexual relationships with partners that are 5 years older than them have a higher prevalence of HIV infection. This could be because can be linked to factors that of unequal power dynamics in those relationships or lack of negotiation for safe sexual practices. And HIV prevalence estimates among 15 to 24-year-olds in South Africa as 6.8% as of 2025, according to Stats SA. There were no stats available for just teenagers or the ages below 15 years of age. So it is therefore important to educate, screen, and treat antenatally for those STIs and contact tracing, as well as initiate treatment where applicable. Looking at mental health, teenagers are more likely to have mental health issues during pregnancy until 3 years postpartum. Depression is diagnosed in 16 to 44% of pregnant teenagers, and they are 3 times more likely to develop postpartum depression. There's no data on teenagers committing suicide, but 12 to 34% of teenagers pregnant have suicidal ideation. So a loss of a child, either by TOP, miscarriage, or stillborn or neonatal death, has greatly increases the mother's vulnerability to mental health issues as well as suicide. So unmanaged mood disorders in pregnancy can result in unfavorable maternal, neonatal, as well as childhood outcomes like a postpartum depression, preterm labor, behavioral and cognitive disorders in their children, as well as high risk of repeat pregnancies. Pregnant teenagers need routine and repeat screen for mental health issues, as there's increased rate of mood disorders in this age group in pregnancies. Another complication of teenage pregnancy is anemia. They're more likely to develop iron deficiency anemia in pregnancy. And the studies have shown that over 80% of pregnant teenagers have depleted iron stores. This can lead to IUGR. Therefore, it is very important to treat anemia in pregnancy. Preterm labor, there's a twofold increase in the incidence of preterm delivery with teenage pregnancies compared to women of ages 20 to 30 years of age. Therefore, teenagers need to be constantly educated on the signs and symptoms of labor so they know. A growth scan is recommended at the gestation age of 32 to 34 weeks to screen for IUGRs. Teenagers are at increased risk for IUGR. More frequent antenatal reviews in the second and third trimester are recommended because they are high risk of preterm labor and preterm delivery. The teenagers are three times increased risk of delivering before 34 weeks of gestation with subsequent NICU admissions. So preterm delivery is associated with severe morbidity and mortality. So, looking at PET and eclampsia, eclampsia is a major cause of maternal mortality, especially in teenage pregnancy. 3 studies in a systemic review and meta-analysis also noted an increased risk of PET and eclampsia in teenagers. Endometritis, according to Sikopa, teenagers have the highest risk of endometritis compared to women of age groups 20 to 24 years of age, and the common causes were found to be recurrent and untreated STIs, prolonged labor and obstructed labor, multiple PV examinations, emergency seizures, as well as poor postpartum hygiene. Looking at maternal mortality, teenage pregnancy accounts for 8 to 9% of maternal deaths in South Africa. A review that was noted by a study that was done at a district hospital, at a district area, a review of causes of maternal deaths among teenagers in South Africa noted a 71% deaths were secondary to preventable causes. Data from a small study at Ekurhuleni noted that of these preventable causes, 35% were because of hypertensive disorders, 24% because of obstetric hemorrhage, 14% because of suicide, and a large number because of non-pregnancy related infections, but they did not give us a percentage. Managing teenagers intrapartum tends to be very uncooperative and difficult to monitor. So they need ongoing reassurance and in labor because they're anxious and they are fearful, and they also need emotional support, and they've been noted to do well with doulas. The issues that are most common in the intrapartum period with the teenagers, CPD, obstructed labor, prolonged labor, increased risk of instrumental deliveries, fetal distress, and cesarean delivery. The most common among teenagers is the emergency, and the emergency account for a highest number of poor perinatal outcomes. The cesarean rate varies according to district in South Africa, ranging from 27% to 45%. Teenagers are also at risk of PPH, either because of the uterine atony due to prolonged labor, obstructed labor, instrumental delivery, or the anemia in pregnancy. They're also at increased risk of infections, either because of multiple PVs or poor hygiene postpartum. So in the postnatal period, so they need to be educated on how to appropriately care for their babies and on healthy diet, and as well as feeding before discharge to ensure that they are competent in caring for their babies before discharge. Teenagers are 50% less likely to initiate breastfeeding, and those who do are more or less likely to continue 6 weeks postpartum. Teenagers with unplanned pregnancies are less likely to breastfeed, and their infants usually are malnourished and develop complications. And then infants of teenage mothers have a high risk of UTIs, respiratory tract infections, GI infections, obesity, diabetes, impaired cognitive functions, as well as low academic achievement and poor adult life outcomes. Multiple studies have also noted that the teenagers have high risk of stillbirths. Looking at contraceptives, they should be discussed at every visit during the pregnancy period and initiated before discharge. Long-acting reversible contraceptives are found to be most effective in reducing repeat pregnancy by multiple studies of up to 97% in a period of 3 years. And also, LARC is a recommended choice because it also reduces the future of unintended pregnancy. Barrier methods should be advocated as well to minimize the risk of STIs, and rapid repeat pregnancy is associated with increased morbidity. Repeat teenage pregnancy rate is around 35% is seen within 2 years of previous pregnancy, and approximately 2/3 of those are unplanned. South African study found a repeat pregnancy prevalence of 17.6% with an interval of 1 to 5 years, and the majority of repeat pregnancy occurring within 24 months. An Australian study found that there was a 77% of teenagers less than 18 years of age resume sexual relations within 3 months postpartum, and 52% they do so without any means of contraceptives. There's also a strong association between repeat pregnancies and the partners that are more than 5 years of age from there. Yes. Looking at sequelae of pregnancy, they usually have repeat pregnancy, there's school dropouts, they have financial issues because they're unemployed and mostly come from low socioeconomic backgrounds. So the pregnancy, it affects their personal relations, and they leads to dysfunctional relationships, feelings of abandonment, and as well as stigmatization. So there is parenting and child rearing difficulties because they lack the skills, and also sometimes they lack the social support. They have physical and mental health issues, and then children of teenage mothers usually become teenage mothers themselves, continuing this poverty cycle. Looking at ethical and legal aspects of teenage pregnancy. So we look at the ethical principles, autonomy. So we need to respect the teenagers' right to make informed choices. Teenagers may lack the legal capacity for full consent. In South Africa, the minimal age of consent is 12 years of age. So clinicians need to respect the privacy and decision makers of the decision-making of teenagers. And there also needs to be a balance between autonomy as well as parental responsibility. Looking at beneficence, we need to be acting in the best interest of the mother as well as the baby, and provide appropriate medical care and emotional support. Non-maleficence, we need to avoid harm to both the baby and the mother, and avoid judgmental attitudes or denial of service, prevent harm from unsafe abortions as well as neglect. When it comes to justice, we need to ensure fairness and equal access to care, fair access of health care, education, as well as social support, and address socioeconomic inequalities and prevent discrimination as well as stigmatization. So there are key ethical dilemmas that includes of mention confidentiality versus parental enrollment, consent when it regards to antenatal care, contraceptives, as well as abortion, stigmatization and mental health effects, as well as responsibilities of the father. When it comes to abortion and moral consent, we'll talk more of termination of pregnancy in South Africa later, but there's ethical debates on abortion in minors that is influenced by religious and religion, culture, as well as law. and thus requires sensitivity and informed consent. Looking at the child, we need to protect the baby's right as well, and their well-being, support the young mother in parenting, and make sure that they have social and psychological follow-up. Or looking at the age of consent, the age of consent is a minimal age which a person is considered legally able to agree to sexual activity. So if sexual activity occurs below the age of consent, it may then be considered a statutory rape. The age differs according to countries. In South Africa, the age of consent is 16 years of age. So sexual relations with anyone below the ages of 16 is therefore considered statutory rape. When a pregnant mother is below this age, then a healthcare professional is required to report sexual activities to the authorities. Rights of consent. Many countries allow teenage pregnancies to consent to medical care related to their pregnancy. And the common rights often include the antenatal labor and delivery services, postnatal care, as well as family planning and services after birth. So consent for surgical procedures as well as cesarean section, intervention or cesarean section, may sometimes still require a parent and or legal guardian. When it comes to confidentiality and privacy, healthcare providers must protect the privacy of their teenage patient. The confidentiality may only be broken if there's a risk of harm, or the teenager is below the age of consent, or there's the sexual abuse is suspected, or the law specifies. So the teenagers have rights to private consultations without their parents, the confidentiality around sexual and health as well as contraceptives. So it's mandatory for healthcare workers to report if there's underage sexual activity, or they suspect abuse or sexual relations with large age gaps, or but this is only to protect the minors. Parental rights versus autonomy. Parents or guardians typically retain legal responsibilities for their minors. However, pregnancy grants many teenagers increased healthcare decision-making autonomy. So if there's a conflict that arises between the parent and the pregnant teenagers, the conflicts may arise between the pregnant teenager and their parents, but in life-saving situations, the medical professionals will have to take the best paternity and child support. When the baby is born, the father has legal obligations regardless of how how old they are. So a child support can then be enforced by law. Paternity may be needed legally to be established. So if the father is an adult and mother is underage, there may be criminal consequences, as we've mentioned. Pregnant teenagers have rights to continue education. So schools cannot expel pregnant teenagers. They need to provide safe accommodation for learning and should not discriminate or stigmatize them. When it comes to abortions, the teenage mother is usually the legal parent at birth and has the right to keep the baby if they want, to decide on adoption and make parenting decision. And unless the teenage mother is deemed unable to provide care, then social workers need to intervene. So we've mentioned that those key ethical principles are to protect the minors and to make autonomy in the health decision, and for the best interest of the child, and to prevent abuse. So looking at South Africa, so a child is regarded as anyone below the ages of 18. So looking at Child's Amendment Act, a child of 12 years and more with mental capacity to understand the risk of and benefits of a medical treatment or HIV testing may consent to their own behalf and to surgical treatment with the written assistance of their parent or a legal guardian. So for surgery, both the child and the parent or guardian must assent must be written, and if the child and a parent they disagree, then the hospital superintendent or the minister of the High Court must then be contacted, and then depending on the urgency of the procedure. So this is unlike the previous Child Care Act of the 1983, where the child needed to be more than 14 years of age to consent, and also for surgical operations, they needed to be more than 18 years of age. Looking at the choice of termination of pregnancy, so pregnancy may be terminated until 12 weeks upon request, needs a consultation with a medical practitioner from 13 to 20 weeks, and after 20, with consultation with a medical practitioner, as well as another or a registered midwife. So with the termination of pregnancy, it can only be carried out with, by medical practitioners. So the Child Care Act does not apply to termination of pregnancy because it would then defeat the purpose of the act if only girls above 18 of age would be allowed to consent. So when it comes to national health care, everyone has a right to access to health care services, including reproductive health. So anyone can, so a healthcare service may not be provided for a user without their informed consent, only if they are unable to give consent. But what's important is that the healthcare professionals must take all reasonable steps to obtain the user's informed consent. And as we've mentioned, informed consent means that the consent is provided with healthcare, specified healthcare service given by a person with legal capacity to do so and who has been well informed. So just to add on the recommendations that we did not mention in the talk, it is recommended to do a routine repeat screening of alcohol use, substance use, as well as violence in pregnancy, as because of their increased rate in pregnancy. Also, pregnant teenagers should have nutritional assessment, vitamins and food supplementations if they need it, to access to strategy to reduce anemia as well as low birth weight and to optimize weight gain in pregnancy. So pregnancy should be recommended, breastfeeding should be recommended, and sufficient support given to those population at high risk for discontinuation of breastfeeding. So in conclusion, teenage pregnancy is a global burden. There has been a global decrease, but the decrease is uneven, with sub-Saharan Africa still having the highest rates. South Africa has the highest rate of teenage pregnancy rates worldwide. The pregnancy rate is also coupled with a burden of HIV co-infection. Teenagers can be teenage pregnancies can be associated with worsened perinatal and neonatal morbidity and mortality. So interventions are needed in place to assist with high risk teenagers. Thank you.
Thank you, Dr. Nakele, for the broad overview. Before we carry on, I think we can just highlight some of the few points. I know in South Africa, especially in primary healthcare settings, they have set up youth-friendly services. Unfortunately, we don't have that. Well, I haven't seen it in regional hospitals. And youth-friendly services ensure that teenagers can access healthcare, screening for STIs, contraception during hours that they are able to come. So they open the clinics mainly for them. In the facility where I used to work, we used to open between 7 and 8 to ensure that they can come and access treatment, and also between 4 and 5. So the management discusses with the staff about the working hours. But I'm not sure if that happened. Maybe Dr. Moran will help us with that in other hospitals, district hospitals, as well as regional hospitals. And in terms of ethical and legal considerations, there are lots of debates around it. The example that you may put across is if you're a mother and your child is still under your care, is on medical aid, and you send them to a gynecologist and they you don't know that they're pregnant and they say they want termination of pregnancy. Do you just get the bill on the medical aid that your child was undergoing TOP? Your 14-year-old that you took to a gynecologist? How far does it go? But unfortunately or fortunately, the law protects them and they have a right to have termination of pregnancy, and you're going to have to pay for the bill as well. But there are lots of ethical and legal considerations in teenage pregnancy. I'm going to open the floor to questions, but maybe Dr. Moran can lead us in terms of youth-friendly services across the province, because I think the main problem which we see at Eddington, the main problem that we see from the students, because we have a lot of residences around, is that they don't have time to access contraceptive care, or those who have are not well educated on how to take contraceptives or the importance of contraception without judgment. So I'm just going to ask Dr. Moran to comment on that, and then I'm going to take the questions from the floor.
I don't have much comment. I think there are youth-friendly services at the times that you mentioned at selected primary healthcare facilities. So it's something that the youth-friendly health programs are trying to promote. And I think in various districts, in certain clinics, it's been set up. But I'm not much aware of it at hospitals. It's more at a primary healthcare level, which would be fine for accessing contraception. But anyway, even if you have a youth-friendly service at a clinic, it doesn't mean a teenager is going to go all the way to the clinic to access that service. So I think there's a lot of discussion about health services coming to schools and maybe prioritizing schools with a lot of pregnancies amongst the learners. And there's this debate about whether it's acceptable for health services to come to schools and offer contraception, amongst other things, to the school learners. And it has been done, like, for example, setting up a mobile clinic outside the school and at certain specific times of the week. And I think there are examples where it's had quite a good effect, including the contraception issue. But we also hear stories that most schools are unwilling to promote that service. What they say is that the school governing body is against it. I'm not sure it's even been properly discussed with school governing body. It seems to be an automatic answer. But as long as the issue of teenage pregnancy is put as being a problem for the health service, then this problem may continue. Because I think, you know, if you have targets for reducing your teenage pregnancy, then it shouldn't be the health service that is given that target. It should be maybe the schools or the police or those kind of departments. Then they might work harder to try to address that issue.
Thank you, Dr. Moran. I'm going to open the time for the questions from the floor.
I think the one area that you quickly ran through it, which was of interest, is the consent story in terms of cesarean section, especially. You just ran through it and accent and what have you not, and said effective from 2025. But you probably needed to clarify. Can you clarify for us somebody who's less than the age of 16 or whatever the story is in the cesarean section, who can consent for that? Can the person consent? Do I need to phone the parent for that or not? Because consent is two different stories. What exactly does that Child Act say? Effective from 2025, I think it's 2018 or 2020, effective from 2025.
Yes, it was done in 2022, effective from 2025.
Yeah, what does it say exactly? Can you just, you looked at it now and I see crossed over this. Can you give us some take-home message? What exactly is supposed to do?
Okay, so for surgical needs. So if the needs for surgical treatment, if a child, as we said, the child is anyone below the ages of 18. So if they need surgical interventions, they still need an assent from the mom, the parent or the legal guardian. So they can consent, but they need both of those signed forms are needed if they're less than 18 years of age. So they can consent, but an assent is needed from the legal guardian of the parent.
They need an evacuation. Following an miscarriage.
They yes, it's the surgical, yes. According to the act, they need to consent, but their parent needs to assent according to the act if they're less than.
Eventually, when the parent says, the child is evacuated, say, what do you mean? What is the procedure for? That the child is there. Is that not contradictory or?
It is,
I mean, for the Caesar, it's straightforward. I mean, there was a big stomach, it was seen, it was conceived. But for a patient waiting for evacuation, and even the termination, obviously, we just teach us misoprostol, but obviously Maris-Stopes does manual vacuum aspiration. So are they seeking the assent of the parent for the manual vacuum aspiration?
It's very confusing, Dr. Maise. I think the problem is that when it's still regarded as termination of pregnancy, a child of any age can give consent. But when it's regarded as surgical intervention, then the child needs to give consent and the parent needs to give assent.
I think the Termination of Pregnancy Act is an exception.
Yes.
Provides an exception to the normal Child Care Act. To be honest, I'm not familiar with an update in 2025. But the Termination of Pregnancy Act says the child, if it's a child, must be counseled or advised to consult with the parent or guardian and so on. But if they refuse, they shouldn't be denied the termination of pregnancy because of that. So it says that, and there's no age of there's no minimum age of consent that's written in the Termination of Pregnancy Act. So you can advise them to consult with their parents, but if they refuse, then you can still proceed if the person is requesting the termination of pregnancy and meets the criteria.
So you can proceed and do a hysterectomy too, if they need a hysterectomy for complications of the termination of pregnancy.
Well, the problem is only termination is for a child of any age, for any woman of any age. But the management of complications would include both medical and surgical and needs a parent because they need to get assent most of the time because it's usually the surgical intervention.
You know, the guys that were involved in crafting the termination of pregnancy, and one of them who was part to that was Professor Adam Sanger was before. And it was intended to, and they deliberately left it vague. It was intended to cover the cesarean section because when you do a Caesar, you're terminating a pregnancy. Although for us, termination means obviously the outcome is that there is no live outcome, but it's the pregnancy coming to an end anyway. So it is this confusion or that really creates a problem in terms of that, because they in their minds they're trying to cover that part, but people have raised a lot of issues about that, and that's why we are confused now, because it doesn't make sense to say a patient who now requires evacuate. Termination is okay already. Misoprostol has been taken, that's termination. Are we together?
Yes.
But now evacuation is required. Evacuation is not termination. Evacuation is a surgical procedure, which obviously is now dealing with the fact that there's retained products. And so do you now say that falls under termination of pregnancy or whatever, this evacuation, this hysterectomy that now follows a termination of pregnancy? Do you now say it's an exclusion, it's an exception imposed on the termination of pregnancy. Do you say that? Is that what is intended to be said?
Unfortunately, no.
If the person is consenting or requests a termination of pregnancy and you're doing it accordingly, and the person is under 18, then you can do the evacuation as part of the termination of pregnancy. Because if the person has come and said, I'm requesting a termination of pregnancy, and the decision is to do it via manual vacuum aspiration, then that can be done without getting the parents' consent.
Yeah.
But if a person comes to hospital as a teenager, or as a 15-year-old or whatever, not that they've gone for termination of pregnancy, at least officially, they haven't gone to a legal side, it just comes in and has got an incomplete miscarriage and needs to go for evacuation, then I think they have to get the consent of the parent. The assent of the parent.
Yeah, that's why I'm saying it's complicating a story, because we do know that nobody is going to say, I want to do misoprostol. And we are now seeing a lot of misoprostol even taken in the third trimester. So a person has done the termination, but now they've got retained programs, and now they need evacuation. Termination has occurred already. Now they're coming with this, and now you say, no, let's call the parents now.
Yeah.
And ask them whether we can go ahead and do an evacuation. So the parent says, what evacuation for what? For what are we talking about? And we say, well, your child was pregnant. Now, are we now not violating the confidentiality? The child doesn't want the parent to know that they're pregnant. It's a kind of South African conundrum, I think, because of the way we are crafting this kind of acts, I think.
Yeah, I will put it, there's another sort of way of looking at it. Let's say there was an agreement that such cases, you could just proceed without discussing with the parent. Then what would tend to happen, in the middle of the night, the doctors wouldn't bother to contact the parent. They'll say, no, it's okay, the child's allowed to request and we're allowed to do it. Then you go ahead and do it. Let's say there's an anesthetic accident or the patient has a perforation and leads to death. Then the parent will have to be informed, oh, your child died. So I didn't know anything about my child. Why didn't you contact me to discuss the procedure before you even go ahead with it? It might just be because the staff, because they had that leeway, they just went ahead and did the procedure without discussing. And it can happen with the Caesar as well. People don't want to go through the trouble of phoning the parent, trying to locate the parent. They would like to just go ahead and do the Caesar. But what happens if something goes wrong? Maybe the parent was well aware that the child was pregnant, but the child then turned up at hospital without the parent knowing. And, then there would be, I'm sure, legal consequences. If the parent could say, well, why wasn't I consulted? I wouldn't have agreed to an anesthetic and so on and so forth.
So the termination of pregnancy acts that are not informed.
Yes.
TOP.
Yeah, TOP is that are not informed. Then so, but anyway, as I say, it's but one thing I always find with this discussions of teenage pregnancy, I don't know whether we are trying to be politically correct. I never get to hear that we just say teenage pregnancy in South Africa, this and this, but we never categorize it according to racial groups, because I'm sure there's a difference in terms of various races, in terms of teenage pregnancy rate in white, in Indians versus Africans. And my suspicion is that it's higher in Africa. Whether you ascribe it to low socioeconomic stories is a different story. But then we need to be asking ourselves, if it's higher, and I stand to correct him, if it's higher, why is it higher in Africans? Why is it lower in Indians and lower in white people, in white teenagers? They are also sexually active. Why? And it is that why that is not being addressed, and we keep going between the Department of Education, the Department of Health, not coming to some decisive action in terms of that. We'll keep talking about it over and over again. We're never going to succeed in this story because we're not addressing it holistically. We know why it's happening more with us than it's happening with them. but that is not being addressed in terms of that. And we keep talking about this and that and that and that, or whatever the story is. And my suspicion is that obviously the white children are on contraception.
Yes.
Ours are not on contraception. So why can't we address the contraception issue in the Africans themselves? And we keep putting everybody, teenage pregnancies higher in South Africa. No, it's higher in Africans. Let me just say, it's higher enough. Not because they're slim skills or whatever the story is, because we are not doing what needs to be done. And until we can have the courage of our conviction to do that, we are wasting our energy talking about the stories and what have you know, all that kind of story. And obviously we say, oh, health care provider is supposed to report. But what? And who's going to do what about the report? Because obviously we are legally supposed to report that this is somebody who falls pregnant before a certain age. And then the parent comes, no, we've discussed it. And nothing comes out of it. It's just a situation that you say, well, then we just wilding away time.
Dr. Maisa, I think when it comes to, well, it's not from any clinical trials, but I think we Black parents or African parents need to be educated, need to develop courage to talk to teenagers about contraception, because I think there are lots of cultural and religious norms that stop parents from talking to their teenagers about accessing contraception. I don't think a lot of African moms are brave to say to their 14-year-old, I see you have a boyfriend, I see you have sex, let's go and get contraception. It's something that is not usually done in that context, and I'm not sure why.
Do you think that's usually done in the Indian and white population?
Okay, okay. I'm not sure about the Indian population. I know some of them are very conservative, but a couple of the white counterparts that I know that there's an open conversation about sex, there's an open conversation about what relationships, there's an open conversation about bringing the boyfriend home and talking openly about a lot of issues.
Are these like highly educated white?
Well, my knowledge is very limited, Dr. Moran, so it's not from any clinical trials. I'm just saying something that I've observed.
But why is the pregnancy rate lower in whites, whether they are educated or uneducated? Why is it so low? I mean, it's definitely lower, and we don't want to confront that elephant in the room. Why is it?
I mean, the white population. I haven't seen those stats, as you said.
Yeah, because nobody wants to produce them, because it's not correct.
Yeah, but I don't think we should make assumptions. That is because the white population of teenagers are using contraception. I don't think we should make that assumption. That research can be done and looked at.
Nobody's ever going to do that. It's not politically correct, but it's a fact that obviously when we look at it, I mean, if you look at the public sector now, even if you look at when we still did provide termination of pregnancy, and obviously the public sector was open to all races, and look at the people that came through, it was not white children that are coming through with termination of pregnancy. It was ours that were coming through. So you say, are the whites just going to the private for termination or what? And it's not very likely because not all of them can afford the private, but it's ours that are coming. In terms of that, so there is no question about, and I don't think there will be a difference in terms of sexual activity between races. They are just as sexually active as ours. But
Do you have research on
that? I need to research that now.
Valid, but I'm not sure we know the answer.
No,
I think you're speculating.
Yeah, I'm speculating, but I'm sure it's a clear, story. Yeah, anyway. Yeah.
I'm going to take questions from the online audience. Okay, if there are no questions, thank you very much. Have a good weekend.
So I just want to make one more point here. So I think Dr. Maisa raised the issue of that the Termination of Pregnancy Act could be used to address issues of consent for emergency Caesar. And that would be for the third category, where it's over 20 weeks, where it says termination of pregnancy can be offered with the decision of a doctor. You would have to discuss it with another doctor, or a professional nurse.
Yes.
And it would be if the mother's life's in danger, or if there's the second one, which is more for the sort of classical TOP, is if there's a severe fetal abnormality, or the third one is if there's a risk of injury to the fetus with the continuation of pregnancy. So the risk of to the mother's life or the risk of injury to the fetus, those are basically like Caesar indications for emergency Caesar. If there's APH, or if
Fetal
there's
distress.
Fetal distress, or if there's obstructed labor or something like that. So yes, technically, I did ask this question to Professor McCoy Mason, who was a lawyer in UKZN, who was interested in pregnancy-related legal issues, and then he published a short commentary on that, I think in the SAMJ, where I think his opinion was, yes, you can use the TOP Act for that. But that's not to say that we should always be doing it. It's much better to get assent from the parent if you can get that. So that TOP wording shouldn't be used as an excuse for people not to try to communicate with the parents and discuss what's happening. But in situations where you can't get in touch with them, then the TOP Act will probably cover you as long as the Caesar is being done for those indications.
Yeah, it's only done for maternal or fetal interest. That's what the Caesar is done for. It's an area that when it was discussed earlier on, when whatever, and we had a lot of disagreement with the sisters in theatre, because we were saying, no, that's clearly states it's written in black and white. And that if you want to terminate the pregnancy for mother or fetal interest, this is covered in termination of pregnancy. No. And the Department of Health didn't come to our assistance in terms of them putting their foot down and say, yes, it's covered. You don't have to call anybody. Because how would the child come here with a big stomach and the parents don't know the story? The child's pregnant and must come in to receive health care, which might include a cesarean section. They know that, but what you find is this reluctance in just putting it in black and white. You said legally, it is correct and it's covered, that you don't have to, but it's advisable that you do it. And in the current state where the telephones don't even work, where we're using our cell phones to do the thing because the Department of Health did not pay the bill for the telephones. You just make our life very difficult. Can you put it clearly, black and white, the Department of Health? Yes, it's covered. We can go ahead and do a Caesar without calling the parent. Why must we are so busy, we are overworked, we must not even call parents and things like that. It's just not on.
I agree, Dr. Mason.
No, I don't exactly. Even according to CTOP Act, you must advise the child to discuss with the parent. You must make efforts. According to the Child Health Care Act, according to the TOP Act, you must still try to contact the parent. And I think that's the danger, that if that becomes normalized, then doctors will become lazy and they'll just say, no, we don't have to call the parent, it's covered by the TOP Act. You should still try to call the parent. It's a 15-year-old or whatever.
That's what they said. It's Constitution of South Africa, which is loaded everywhere. Doesn't work for the country. This is the classical example. Doesn't work for us, but it's beautiful, written beautifully and everything else, but it doesn't serve the interest of the subject of the Constitution and exactly the story. It doesn't serve us as doctors to be calling for a pregnancy that's known and the person needs a delivery. Delivery can either be normal or cesarean section. Why must I be calling? Whatever the story is, why? Why must we call? In whose interest is that calling?
If it's your child, you want to know.
No. I mean,
What's
the
that
child.
child?
No.
Thank you, everyone.